Hi everyone and welcome to another Michigan Medicine live event. Here at Michigan Medicine we like to cheer Go Blue for our teams, but during the month of March we cheer Go Blue for Colorectal Cancer Awareness Month, which is represented by the colour blue. So today we're here with two of our physician experts who will be talking about prevention and treatment of colon and rectal cancer. So let's meet our experts, Dr. Keith Naylor, Dr. Karin Hardiman. And if you guys could just tell us a little bit about yourselves, if we could go for you first, Dr. Naylor.
So it's wonderful to be here. My name is Keith Naylor. I'm a general gastroenterologist. I originally was raised in Michigan, in Kalamazoo, Michigan, and I attended the University of Michigan for undergraduate and medical school education. And I'm a general gastroenterologist, which means I see patients with various different types of digestive disease issues, but I spend probably about 20% of my time doing colorectal cancer screening in terms of like screening colonoscopies and other procedures. And then also I perform research as well, trying to increase the uptake of colorectal cancer screening to try to see if we can get as many people screened as possible. So I think that's generally what I do, but I'll be happy to add more as we talk.
That's fantastic. Dr. Hardiman?
Yes, I'm a colorectal surgeon here at the University of Michigan. I've been here almost 8 years, and I'm also the multidisciplinary cancer clinic surgical director at our multidisciplinary colorectal cancer clinic at Michigan Medicine, where I see colorectal cancer patients. Surgically, I specialize in lots of different types of GI cancer, such as Dr. Naylor, but predominantly colon and rectal cancer.
Thank you, thank you. Just a reminder for anyone that's tuned in, you can submit your questions at any time, even now, for our panelists to answer during this Q&A. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. Now, if you prefer a more anonymous option, you can also send a private message to us via Facebook. If you can't stay for the whole chat or want to share the recording of this Q&A with a friend, a video of this in its entirety will be available on our Facebook page later today and also posted to the Michigan Medicine YouTube channel soon after. So before we take questions from our viewers and before we move on to the bulk of our questions, I was wondering, how common is colorectal cancer in America?
So it's generally about a little less than 5% of the population that would be affected by colorectal cancer. So that's about 1 in 20, a little more than 1 in 20 individuals. Overall, the incidence and mortality from colorectal cancer has been decreasing over the last 20 to 30 years. And we believe that's due to multiple factors, but in regards to what we're talking about today, one of the biggest would be the increased uptake in screening and prevention of colorectal cancer. It's still one of the most common forms of cancer, as well as one of the most common causes of cancer-related deaths. So even though we've done, I think, an improving job over time of decreasing sort of a lot of the issues related to it, it's still a major public health issue. And I think months like this gives us an opportunity to really focus on that. But there's still many people affected by it, up to several 100,000 people, 500,000 to 700,000 people a year can be affected by colorectal cancer. So it's certainly still something that is a very important issue that people should be aware of. And I'm glad that we're here to talk about it today.
I'm glad you guys are here.
Yeah, nationally in the U.S. it's the third leading cause of cancer-related death. So it is a very big deal.
Yes.
And even though we've seen over time this decrease in incidence across the board, we actually more recently have seen an increase in younger people who are getting colorectal cancer for unclear reasons.
Thank you for that. Next question that we move on to, what causes colorectal cancer?
So we think it's probably a combination of genetics and environment. It's ill-defined. There is certainly a certain population of patients, probably around 20% of patients, where it's pretty clearly familial, meaning either they have a family history of it or they're the first in their family to have a hereditary cause for colorectal cancer. But for the vast majority of people, it's unclear what caused their cancer. And most people with colorectal cancer have no symptoms, which is why there are screening guidelines so that we can start and find it early enough that it's treatable.
Absolutely. Are some people more at risk for colorectal cancer?
So as you're mentioning, one of the bigger risk factors is having a family member with a history of colorectal cancer. Could be a sibling or a parent or even a grandparent, or sometimes even relatives that are more distant than that. But the closer the family member is to the individual, usually the more direct effect it can have on the individual's risk. Other than that, the other risk factors that individuals can't really control would be things like other conditions that cause inflammation in the colon, like inflammatory bowel disease. Those patients also have an increased risk of colorectal cancer. Other familial related or genetic causes of cancers can have increased risk of colorectal cancer, and we'll talk, I think, about some of the specific types of diseases that can do that. But then in terms of the things we can actually modify, smoking, like many other cancers, can have an increased risk of colorectal cancer. There's some ideas that weight or having an increased weight can also have an effect on that, and our diet and exercise also seem to have an effect on colorectal cancer risk. But I would say that the biggest risk would be a family history of colorectal cancer, and then having a disease that may increase the risk, like inflammatory bowel disease or the familial causes of colorectal cancer.
The next question that we have, what's the difference between rectal cancer and colon cancer?
Yeah, so often this is really important when we start thinking about treatment. Patients rarely, we were talking about this earlier, patients rarely ask us if they have one versus the other. We kind of think of it in one bucket, but the treatment paradigms are pretty different, and so it's important for us to differentiate. The rectum is actually the very last part of the large bowel or the large intestine, and it's in the pelvis. And the difference from a long-term perspective is really that it's got a higher local recurrence rate, meaning it's more likely to come back where it started than colon cancer. The local recurrence rate for rectal cancer historically, before we had the treatments that we do now, was up to 50%. So now it's more like less than 10%, but it's still higher than colon cancer local recurrence, which is around 2%. So the treatment is different, and so we try to figure out, is this in the rectum or not? And that's really based on our endoscopy and our exam, and that tells us how far from the outside world it is, and it's really just in that last 10 to 12 centimeters that we think of that as rectal cancer.
Interesting. Is colorectal cancer a fast-growing cancer?
So I think it's an interesting question. A lot of patients ask me this when we're talking about how quickly do they need to get in for surgery, how quickly do they need to start treatment. And I would say it varies quite a lot. For most patients, it's probably not super fast, but I have seen particular patients where it is faster than we expect. This usually comes up when we're trying to schedule a surgery and people are worried about, doing it very soon. But in any given patient, we don't know how quick it's going to grow because we don't have multiple points in time where it's been there and we've been monitoring it. Once we diagnose it, we generally start to treat it. But we think of a polyp or a precancerous growth as taking 5 to 10 years to become a cancer. And so that's where our screening guidelines come from, is actually the time frame in which it takes to grow. So any time someone comes to me with a colorectal cancer already, it's probably been there a while. So we want to make sure that we get an appropriate workup, get all the information we need, make sure the patient's healthy enough to undergo treatment, and then we move forward.
Thank you for that.
Yeah, and I think one other thing that comes up in my conversations with patients frequently is because of screening, many times we're able to identify or diagnose the cancers at an earlier stage.
Yeah.
And we talk about staging, but sometimes people may not be aware of what that refers to, and it just has to do with kind of the depth at which the cancer is involving the colon. So cancers that are very superficial show signs that they've become cancerous, but they haven't really invaded through or all the way into the outside of the colon. So the more the cancer is sort of isolated to the surface, the more likely it is that it's not going to be a fast-growing tumor or cause greater mortality related to the cancer itself. So one of the goals of screening is not only for prevention of cancer, but to diagnose it at the earliest stage possible, so that when we send patients to surgeons like yourself and oncologists, they can get the best outcome or potentially even a cure after the cancer has been diagnosed.
Right, for sure. So as I think you're saying, when we are able to scope patients, through screening, we can prevent colon cancer by taking off precancerous lesions or adenomas, and that is a very good outcome. And then if we catch the cancer early, actually colorectal cancer is highly curable.
Fantastic. And my question for you, Dr. Naylor, does colorectal cancer affect men and women differently?
So that's an interesting question. I think that there's still a lot of work being done to help answer that. In general, when you look at mortality and incidence, the incidence and mortality of colorectal cancer is higher in men. Some of that is due to how often people utilize the healthcare system in screening. So women are usually better at actually going to their physicians and undergoing the recommended screening at the recommended times. So some of the effects that we see with men having a higher likelihood of dying from colorectal cancer has to do with them presenting later in the disease process or with more advanced cancers. But there is some idea that men do tend to have a greater number of adenomas, which are the types of polyps that have the risk of developing into cancer. So there may be some genetic factor related to men that also may have some increase in their risk of developing cancer even outside of them potentially having screening at the recommended time. But a lot of the factors that we actually see in outcomes could hopefully be erased if we all equally were able to undergo screening at the recommended intervals.
Okay, the next question that we have, what is Lynch syndrome?
So we probably will both talk about this to some degree. So we mentioned earlier that some forms of cancer have a genetic or familial component, and that basically means that an individual can have a risk that they can then transfer on to their children or grandchildren. And Lynch syndrome is one of the more common types of familial types of colorectal cancer where the risk is higher in those individuals. The other name for that is hereditary non-polyposis colorectal cancer. And essentially, it's a condition where individuals, when they develop a polyp, that polyp has much higher chance of going from a precancerous polyp to an actual colorectal cancer. I think the thing for individuals sort of non-healthcare providers to know is that it's very important to know your family history, because the way we usually identify these patients is because their grandparents, parents, or their aunts and uncles may have a history of colorectal cancer, particularly cancer that's diagnosed early, before the age of 50 in particular, can be a sign of someone having a genetic predisposition for colorectal cancer. And there's sort of a handy rule that sometimes we use where if you have 3 relatives that you know of with a history of colorectal cancer, and it goes across 2 generations, so meaning yourself and then either your parents or grandparents, and then if one of those individuals has a history of being diagnosed before the age of 50, then that's definitely something that you should talk to your doctor about, even if you're not at the age of screening. And there's other testing that can be done to see if someone has the actual genetic genes that actually diagnosed Lynch syndrome. But those are sort of some of the things we use to isolate out the high-risk population.
Yeah, you were talking earlier about patients whose cancer gets worse quickly, and actually Lynch syndrome patients is one group where that's definitely true. Not only do the polyps progress more quickly, but the cancer can become a worse stage quickly. What happens in Lynch syndrome is there's a problem with the ability to repair the DNA. So all of us throughout our whole body, we're making new cells all the time where cells have died. And in Lynch syndrome, anytime a mistake is made, it isn't fixed properly. So we all make mistakes when we make new DNA to make new cells, and those mistakes get fixed. But if you have Lynch syndrome, the mistakes don't get fixed, and so it pretty quickly adds up problems. When patients come in and we know they have Lynch syndrome, then we consider what the best surgery for them would be. And so in some patients, we actually, especially if they've had colon cancer more than once, we actually sometimes will recommend to take more of the colon than just the part that has the cancer as a preventive measure. The other alternative is to do colonoscopy more frequently, about every 1 to 2 years. And again, in most patients, that's enough to keep them from getting colorectal cancer. But depending on their overall risk and their history, sometimes we recommend taking more of the colon out.
Thank you. Next question that we have, it's a treatment question. What is the typical treatment for colorectal cancer?
Right. So for colorectal cancer, typically we have patients come in and we want to know the answer to a series of questions to understand how bad it is. Where are we starting from? And so we want basic blood work, and we want CAT scans of the chest, abdomen, and pelvis. And the purpose of those is really just to tell us, has it moved on from where it started or not? In addition, we want a full colonoscopy all the way around the colon so we can know if there's any other problems going on and so that we can identify where the problem is. Usually the endoscopist, if it's not in a very clear location, will tattoo, meaning put dye in the wall of the bowel so that we can see the tumor from the outside surgically. As long as the tumor hasn't moved on to other parts of the body, which is called a stage 4 cancer, then the first step for colon cancer is actually to remove the tumor surgically, which we can do either laparoscopically or through a bigger open incision. For rectal cancer, it depends on the staging. We have to get a couple of extra tests to see how far through the wall it's gone, and that changes whether we can either cut it out locally through the anus or they need chemotherapy and radiation before we remove it. There are a lot more factors when it comes to rectal cancer.
The next question that we have, is immunotherapy available for treatment?
So interestingly, the only patient population who has colorectal cancer who responds to immunotherapy is patients who have what's called MSI high tumors. So MSI high tumors, patients who have Lynch syndrome have MSI high tumors, but also up to about 20% of all colorectal cancers actually are MSI high, which just means they have a lot of mutations. Those patients we know respond to immunotherapy, and all of the other patients who have sort of more standard or the more common colorectal cancer, they don't actually respond to it, so it's not used. And we don't know of a benefit for patients unless it's metastatic, meaning it's moved on to other places already, for immunotherapy in colorectal cancer, so it's not part of the initial treatment.
Thank you for that. The next question that we have for you, Dr. Naylor, does colorectal cancer affect people of different races the same way?
So this is a particular interest of mine. I think that it's an answer that's a little bit gray in terms of race. Oftentimes we use race as a proxy for biology, but it's not always that easy. There's a lot of things that go along with race and how individuals are able to access the healthcare system. In general, when you look at the mortality and incidence for colorectal cancer, it is within the U.S. highest amongst African Americans, both men and women. And then typically the next racial group would be the white population, white Americans, both men and women, and then Hispanic and Latinos, and then generally Asians and Asian Pacific Islanders would have the lowest incidence in mortality. Much of that, when they look at genetic sort of causes of that, there seem to be some factors in individuals that they can detect, but it doesn't really explain the overall differences in the populations as a whole. So some of this could be actually more due to insurance-related issues, because we know individuals with more insurance that provides sort of earlier access to these screening and early detection and treatment generally do better. So that may have a factor in it. Also, diet that we have, to some degree, our cultural practices may have some impact in this as well. So certainly race can, in some ways, unfortunately predict the likelihood someone is going to potentially die from a colorectal cancer. I don't believe it's probably due to a biologic factor. It's probably multiple factors that come together to make that the case. Excuse me.
Thank you for that. Thank you. The next question, does HPV cause rectal cancer?
No. So HPV stands for human papilloma virus. It causes a lot of problems, but it does not cause rectal cancer. In the region, if we're talking about the large intestine, it causes actually anal cancer instead. So rectal cancer is an adenocarcinoma, which just means it originates from the inner lining of the bowel, whereas anal cancer is actually a squamous cancer, which means it originates from the skin.
Okay, thank you for that. Are there clinical trials available?
There are lots of clinical trials. As a surgeon, I don't we have some clinical trials open surgically, but most of the clinical trials are around treatment in terms of chemotherapy and radiation. We have several open in our cancer clinic, and we're always looking for patients to match trials up with.
Okay. And in terms of treatment options, What new options are on the horizon for treating colorectal cancer?
Yeah, so this is actually also my area of research. I study cancer genetics and trying to understand how we can better match up treatments with patient. For rectal cancer, several groups noted long ago that a certain percentage of the patients, probably somewhere between 20 to 30% of patients, will have a complete response if you give them radiation and chemotherapy before you do the surgery. We go to take out the tumor, and we give it to the pathologist, and they look at it under the microscope, and there's nothing there. And so the questions, as part of my research and actually more growing interest nationally, is who are those people, why do they have a complete response, and how can we increase that for other people?
Thank you for that. The next question we have for both of you, what are the symptoms of colorectal cancer?
So one of the reasons we're talking here is because the most common symptom is to have no symptoms.
Yes.
So the biggest thing I think we'd probably both say that we want to put forth is the importance of screening, even if you're feeling completely well and you don't have any symptoms. But the things that we usually talk about in terms of if someone was to develop a symptom from their cancer, it can be anything from having blood in the stool to weight loss for unknown reasons to, in some cases, abdominal pain. But I'd say the most common would probably be blood in the stool. That's typically what most people can initially present with. That doesn't always mean that it's a colon cancer. There are many reasons why there can be blood in someone's stool, but it does mean that someone should fairly urgently receive evaluation from a physician to undergo further testing. The most common reason for blood appearance in your stool is most of them are very benign, like hemorrhoids and other kinds of issues that otherwise healthy people can have. But certainly if you see something, you should talk to your doctor about it to determine if further testing is necessary and what testing might be best for that particular individual. But yeah, unfortunately for this cancer, the most common symptom is no symptoms. So screening is really forefront in prevention and early detection of the disease.
Yeah, I completely agree with Dr. Naylor. And I would add, screening for most people who don't have a family history, the recommended age starts at 50, although that may be changing. So that misses a lot of the population who are younger and who have less likelihood of having colorectal cancer. But if patients who are younger or older develop symptoms, then that's a different category. That's not screening, that's investigating something that's already happening. And so even if you're not of age to have a colonoscopy, typically for screening, if you're having bleeding, change in your bowel habits that's different, these other symptoms, that really needs to be investigated.
So let's move from symptoms, let's pivot over to diagnosis and prevention. First question here, is colon cancer preventable?
So absolutely. We have very clear evidence that it is preventable. So colon cancer is generally developed from polyps, adenomatous polyps like we were talking about before, which are polyps that have the factors that can eventually lead them to develop into cancer, although not all adenomas do develop into cancers. But we can't sort of predict which ones will and which ones will not, so we remove them when we find them during colonoscopy. But when we talk about adenomas in the colon, we're generally talking about colon polyps, which can have different forms. Some of them look almost like mushrooms, where they come out of the lining of the surface of the colon. Others can be flat, some can even be depressed. So it's very important that when you undergo a screening exam, that the doctor is able to detect and remove all the polyps that are able to be found. I think one of the things that we probably were going to talk about is there are multiple types of screening that are available. Colonoscopy and really CT colonography, which is a sort of a special kind of CT, are the ones that can detect or identify polyps, whereas some of the stool testing is more geared towards the detection of cancer alone or more advanced polyps. But just in general of prevention, it really comes to identifying and removing polyps, which is more directed towards colonoscopy as the biggest preventative type of test for the prevention of colorectal cancer.
Thank you.
Completely agree.
Fantastic. Okay, and the next question we have, that you've touched on this a little bit already, Dr. Naylor. Besides a colonoscopy, are there other testing options that do not require a prep?
Right. So the testing options are sort of being developed over the course of time, and there has been some change over the last several years in regards to which ones are recommended. Currently, colonoscopy is the most commonly performed colorectal cancer screening test, with probably between 70 or more % of people will undergo a colonoscopy, but it's not the correct test for everyone, and there are other tests that have been shown to reduce the mortality related to colorectal cancer. The most common would be the stool-based testing, and there's several stool-based tests available. Some of them are referred to as FIT, or the fecal immunochemical testing, or also guaiac-based testing, which looks for the evidence of blood in the stool. So the stool-based testing are generally looking for evidence of blood, or some of them, like Cologuard, which also is a more recent test, look for evidence of DNA that is more predictive of cancers. So the stool-based tests don't require a prep. They can be done at home and then mailed in for screening tests. So they can be very helpful in individuals who have difficulty accessing screening because of barriers to getting to a healthcare facility, or issues related to the ability to complete a prep. And then lastly, there is the CT colonography, which is sort of a special version of a CT, but you still need a prep for that. So it's really not applicable when you talk about screening without prep.
And then what are the different types of preps available for a colonoscopy?
So the most common type of prep is it's referred to as polyethylene glycol prep, and it's basically a 4-liter prep. So it's 4 liters of liquid that is prescribed by a physician, and then that prep actually acts by just the volume of fluid works to clean out the colon. That's by far the most common type of prep available, and the one that has the most track record for being effective and safe. People don't necessarily always like the taste of the prep, or the fact that they have to drink such a high volume of prep, so there are other preps available. Many of them are preps that try to either reduce the volume that's required to drink, or preps that may come in pill form. Although some of these preps, as the volume decreases, there can be some issues in patients who are susceptible to it, to development of sort of kidney-related problems, because the smaller volume preps sort of rely more on changes in how the fluids in the body are handled, and patients who are predisposed to either cardiac or kidney disease sometimes can have trouble with that. So here at the University of Michigan, we primarily use the polyethylene glycol prep. That's our primary prep that we use because it is the safest and most effective. But if there's someone who cannot tolerate it, they should definitely talk to their doctor, because there are other options available.
Let's circle back. I know that you mentioned Cologuard. What about tests like Cologuard? Are they as good as a colonoscopy in identifying a health problem?
Cologuard is one of, it's not new, it has been around for a few years, but it's something that we're still trying to see how it works on a population level. One of the big sort of discussions I have with people is it really depends on what your goal is when you undergo the test. So these types of tests, their goal is more the identification of cancer at the earliest stage possible. So they don't have as much of a relationship in cancer prevention, but in terms of early detection, we do know that by detecting the cancers earlier, they do reduce mortality related to cancer. So the Cologuard definitely has a place to play in identification of patients, but once you're identified, you still will need to undergo a colonoscopy for the actual diagnosis. And I can tell you that if you do a Cologuard test or these other tests and they come back positive, it does not mean that you definitely have cancer. I've done several colonoscopies on people with these positive tests, and they may have what's called a false positive, where the test is positive, but they don't actually have colorectal cancer. But in many people, it is a very good way of being able to identify the population of people that can benefit the most from screening. So it definitely has a part to play in the overall sort of trying to get as many people screened as possible, because there's not enough gastroenterologists to do colonoscopy on everyone who would be available or appropriate for the screening test. So definitely stool-based screening tests have a very important part to play in the reduction of colorectal cancer.
Okay, the next question, why did my husband get a 1-day prep when I was given a 2-day prep?
That's a good question.
So that's a very important point that we sometimes have discussions with patients about. And even though you may be prescribed a particular type of prep, the way that that prep is carried out may be different in individuals. And many times it has to do with if you have underlying constipation or diabetes or other types of medical conditions that can make it take longer, or require more medication to effectively clean the colon. So that's something that usually is identified on questioning during a clinic visit with your primary care doctor or gastroenterologist or others. And it really would have to do with if you have sort of a history of having infrequent bowel movements or things that make it more difficult for you to, in one evening, be able to clean out the entire colon. So it's something that's very important.
The reason that's so important is the number one predictor of whether you're going to be able to have a good colonoscopy that identifies even small polyps is whether the prep is good or not. So your colon needs to be squeaky clean, and for some people it takes one prep and some people it takes more. And we often get asked about splitting the prep and why we ask for people to have part of the prep and then wait a while and do part of the prep. And that's because even though the split prep often means you're getting up in the middle of the night, the outcome, meaning the cleanliness of the colon afterwards, is much better. So it's important to follow the instructions.
And then the one other thing I'd add is many times the recommendation for a different prep is made after someone may have already had a colonoscopy that was not as clean as we would have liked. And if we're not sure that we could see the entire colon effectively, then that may reduce the time between the recommendation for your next colonoscopy. And at that time, there may be a recommendation for either greater medication or a longer period of time where you're on a clear liquid diet, which is also part of the prep, where we have you just drink liquids for a day or two to try to reduce the amount of material that needs to be cleaned out from the actual medication itself.
Absolutely. Next question, what can I do to make the prep more tolerable?
So I'll take that again. So there are things that we usually recommend when specifically talking about the polyethylene glycol preps. In terms of tolerability, part of it is drinking the prep over a period of time where you're not trying to drink too much over a shorter period of time, because it is a large amount of volume of fluid. And the way the prep is designed is that you don't absorb the fluid into your body like you would if you drank water or some other typical fluid. So it can make you feel full more quickly. So the importance of drinking sort of a cup of prep and then waiting 10 to 15 minutes before the next cup. And these instructions are really clearly outlined in the information that you receive, but taking enough time to drink the prep and then keeping the prep very cold. Some people feel that makes it more tolerable, as well as using a straw, because the flavor of the prep sometimes is not as, people don't necessarily enjoy that. So using a straw to keep the prep in the back of the tongue as much as possible so you're not getting it all over your tongue can sometimes make it more tolerable as well. And there are flavor prep packets that are given with the prep, but I've been told that those don't necessarily improve the flavor of the prep as much as we might like.
The next question we have for you, what happens if the prep wasn't very successful and you find out during the colonoscopy?
Yeah, so
it depends on how bad it is. For some patients, if we can see most of the colon, especially through sort of washing off residual stool, for some patients we can get it to a point where it's acceptable. But as Dr. Naylor was saying, we might recommend a shorter interval, meaning having come back either very soon if it was terrible, or at just a year or 2 years, because we're not able, if there's a lot covering the inside of the colon, we're not able to see it all, and we can't rule out smaller polyps.
Yeah, and I guess the other thing I'd add is when we talk about the risk of colorectal cancer from polyps, the size of the polyp is one of the factors we use to determine risk. And normally polyps that are about less than 8 millimeters in size or so are considered small polyps. Right. But those are the ones that can be missed more routinely if the colon is not as clean. But as polyps get larger, the risk of cancer is higher in the larger polyps. And ideally, we'd be able to see those even if it's not perfectly clean. But the colonoscope that we use to do the procedure has a very small suction, so it sort of limits our ability to clean the colon if it's not just liquid in the colon. So even if it's a prep that's not perfect, it needs to be liquid. If there's solid material, we really don't have the ability to remove that. So that would really require someone to have a repeat colonoscopy, generally within a few months of their initial colonoscopy. So in order to eliminate that as much as we can, we really try to encourage people to complete their entire prep, which allows them to at least get all of the solid material out of the colon.
Sure. The next question we have, will I be awake during the colonoscopy, and what happens if I wake up during the procedure?
So I guess I'll take that one as well. Some people actually choose to be completely awake without sedation during a colonoscopy. Many times those are individuals who would like to return to work immediately following their colonoscopy. Colonoscopy is not routinely a painful procedure. We're not making incisions through the skin, like a surgery typically would be done, but it can have some bloating or cramping during the procedure, which we try to limit as much as possible. Many people do prefer to have sedation, which we do generally provide during a colonoscopy. The most typical kind of sedation that's performed is what's called conscious sedation, or twilight sedation is also sometimes used to refer to that, and that's sedation where individuals are not as asleep as they would be during a surgery, but they're usually not as aware of what's going on. But if we talk to them or ask them a question to respond, they can usually sort of open their eyes, turn around, they can converse, but when you are not directly interacting with them, oftentimes they'll fall right back to sleep. So individuals may come in and out of being aware that they're having a procedure, and that's not something that we actively try to prevent them from waking up. But if they have any discomfort, we can always provide them more medication. If there are individuals who, either because of anxiety or because of a lot of discomfort during procedures, we can use medications like propofol, which are medications that are commonly used during surgical procedures to provide a more deeper level of sedation where people will not really be aware of the procedure at all. So they're kind of different levels, and individuals can talk to the physician about finding the right type of sedation for them.
And the next question, will I remember the procedure?
Most people will not remember the procedure, or will remember maybe just the last few minutes of the procedure where the medication starts to wear off. But as I mentioned, many people may remember when Katie Couric had her colonoscopy broadcast. So it's not something that you have to be completely unaware of the procedure, but many people, because of the sedation, they may have sort of fleeting memories of the procedure itself, but they may not have detailed memories of the procedure. But then they're provided with a report of the findings of the procedure, so that even if they don't remember exactly what was told to them, they have something that tells them how many polyps, where they were, so that they know, later on down the line when the next time they should have their next colonoscopy would be.
Yeah, thank you for that clarification. Next question, do we still recommend a colonoscopy at age 50, and what about younger ages?
So we can probably both discuss this to some degree, but in general, for average risk patients, it still starts at age 50, but that may be changing, as you mentioned.
Yeah.
But I know you work a lot with the sort of higher risk population, and that can affect when the first recommended screening test would be. So I don't know if
so there were recent recommendations put out by the American Cancer Society this year saying that they recommend actually starting at 45 now. Other organizations and insurance companies have not responded yet, and so this I think is in response to the increase in young people that we've seen over the last 10 years in colorectal cancer. So I think that it's moving a little. We'll see how much and whether uptake of that younger age is going to be across the board or not. So certainly screening definitely starting at 50. And then in terms of other populations where we would screen, meaning assess even without any symptoms, at an earlier age, anyone with a family history of colorectal cancer, we recommend screening at either age 40 or 10 years before their family member was diagnosed, whichever is earlier. And then for people where they have known FAP, which is a polyposis, we start actually when they're teenager. And then for Lynch, it's usually somewhere between 25 and 30. And these are for people who know they have this problem in their family.
Yeah, and I think the insurance part is a very interesting piece of it because it does drive a lot of healthcare utilization behavior, and that may be changing in the future, but for many patients, the first time that they sort of have the opportunity to have screening where they'd be able to have that covered by their insurance is at age 50. But as we get more and more information about how patients can benefit from this, that might be changing in the future.
Yeah.
The one thing I would say is that, as I mentioned, right now we don't really have the ability to provide screening for everyone who's due for screening. So if and when they do change that age to 45, it kind of may stretch the healthcare system a little bit in regards to having enough ability to provide screening for that whole group of patients who now are recommended for screening. So those other factors like using stool-based testing or other forms of screening may become important in individuals who live in areas where they don't have direct access to a large healthcare facility that may have the capacity to sort of absorb those patients who are undergoing average risk screening.
Next question for you, Dr. Hardiman. I was told I have a large polyp and need surgery. Is there another way to remove large polyps?
Yeah, so that depends quite a bit on where it is and how large. I and several of my gastroenterology colleagues endoscopically can try to remove large polyps. So if there's a large polyp and it's within 10 centimeters from the outside world, those we often remove transanally in the operating room, doing a combination of just looking and also a special form of laparoscopy where we're doing it through the anus. Then, if it's going to be removed with an endoscope or a colonoscope, I often will refer those patients when I see them to my gastroenterology colleagues who specialize in that type of removal of large polyps. And for a lot of patients, if I've been referred a patient who has a polyp and they've been told they need surgery, I actually have them see a specialist in removing large polyps before I'll offer a surgery. Again, because we want to avoid surgery if we can, but I will say there are definitely polyps that are so big that it's just not possible to remove them endoscopically, but there are special methods that can be used to lift the polyp where you inject under it and then dissect, meaning separate the polyp from the wall. And I don't know if you want to elaborate further, but it can be very effective for certain patients.
Yeah, one of the biggest characteristics of polyps that makes them able to be removed this way is that they arise from the mucosa, which is the very surface layer of the colon. So if we can separate them from the remainder of the colon and remove them, the risk related to that tissue is now gone because it hasn't had an opportunity to invade through any of the further layers. So a lot of these procedures, like they're referred to as endomucosal resection or endomucosal dissection, allow us to sort of remove larger pieces of tissue, but still at that very surface layer, because you want to avoid, when you're removing tissue through non-surgical means, we have to be very careful as to not cause a hole in the colon, which is called a perforation, and that's one of the things that can happen with the removal of very large polyps. But as technology is advancing, we're becoming better and better at being able to do things that previously required surgery. Now many of them can be done through different types of endoscopy or combination procedures, as you were mentioning. So I think hopefully as technology moves forward, that will become even more common in the future.
But hopefully, through screening,
that's right, yeah.
we can avoid having these large polyps.
Yeah, because it usually takes time for polyps to grow to a larger size. It's not typically found in younger patients, although there are some younger patients who can have large polyps.
Very good points there. Next question, will I need a colostomy bag?
So the need for an ostomy really depends on where the tumor is and what the patient's function is already. So for patients who've had surgery on their anal sphincter, radiation already, tumor that involves the sphincter muscle that allows us to be continent and not have accidents with our stool, those are patients who there's not a lot I can do which would not require an ostomy. So those people need an ostomy, especially if I have to remove the muscle of their sphincter to get the tumor out. Then I don't really have a choice but to give them an ostomy. But if the tumor doesn't involve the sphincter and the patient had good continence already, we can do very advanced procedures where we even hand sew the bowel back together in the anal canal to avoid an ostomy if patients wish.
Thank you for that. Are there other treatment options, including natural treatment options for colon or rectal cancer?
So I get asked this a lot, and I think that as much as I would agree with patients and others that say that there are things that we don't understand, I have yet to see a study that gives evidence that treatments outside of what we typically offer in our national guidelines are effective. And so I get asked about CBD oil a lot, and there's really no study, meaning we give it to some people and not to others, that shows that it's effective to treat colorectal cancer. And so when patients feel strongly that they want to add natural things, I often advocate for that in conjunction with the treatments that we know through trials, meaning we give it to some people and we don't give it to others, and then we find that the people who get it are much better off, that they consider accepting these things where we have evidence that they work. And if they want to add things to it, I don't think that's a problem. and we don't know it's effective or it's not. But I do think that there's a reason that we have these standards and that we have standard recommendations.
Yeah, I would say certainly patients have different feelings about medical care and what they're willing to accept in regards to medical care. But I would say anyone diagnosed with colon cancer or any form of cancer really, even if you're unsure about what you in the end want to do, sitting down with an oncologist or a surgeon in certain situations is invaluable, even in the end if you decide to not undergo the traditional types of therapy that we would offer. You need to have the information.
Completely agree.
So I think many times patients, some of the feelings they have about these things are from information they may have found on websites or other sorts of sources of information that may not be either up to date or accurate in regards to what we currently do. For instance, things like ostomy bags and how often those are used in patients. So I think those things, like sitting down with a doctor and really discussing that, and even sometimes talking to patients who have undergone the procedures or had treatment, is very important in informing people so they can make an educated decision, so that you're not sort of in the end after trying something and then coming later, potentially after the cancer may have advanced this stage or become more of an issue in terms of treatment.
Thank you for that. The next question, what can I do to prevent colorectal cancer?
Yeah, so I'm sure we probably both can talk about this. So screening is probably the number one thing that everyone can benefit from in regards to prevention of colorectal cancer. And that's not just screening in general, but talking to your doctor, even if you're not at the age of screening, or knowing your family history so that we know if we need to start screening earlier. So being very aware of your medical history and talking to your doctor about when the appropriate time to screen is very important. And then in terms of things that you could do yourself, smoking cessation. That's probably the second biggest thing, is to avoid factors that can increase the risk of not only colorectal cancer but other cancers. Diet and exercise would probably be the other major influencer in trying to reduce the development of colorectal cancer. There have been a lot of studies looking at other things, from everything from vitamin D to the use of aspirin, and these studies have shown some improvement in certain populations, but I don't know if we're able to really recommend them on a population level at this point. So in terms of prevention, I would say just living a very healthy lifestyle and being an advocate for your own care and accessing care regularly would be the biggest things that have been shown to have the biggest factor in prevention and early detection.
Yeah, I agree. And even in patients who've had treatment for colorectal cancer and are now in what we call surveillance and survivorship, all of those things are still true. Mm-hmm. And so we know that people who have a healthy diet and exercise regularly actually have even a lower risk of recurrence of their cancer later after they've had cancer. So it's never too late.
Thank you for that. Let's talk about family health history. How do I complete a family health history?
So I'm sure you probably have a lot of experience in this with the younger population. So it starts with just asking questions and really getting to know your family history on a personal level, but there are individuals within the healthcare system. Generally, they are genetic counselors who are specialists in sort of going through an individual's family history and really finding out more about all the different aspects of family history, because sometimes you can have a particular type of cancer and it may actually influence other forms of cancer. So we talked a little bit about Lynch syndrome, which is colorectal cancer, but some of those individuals may actually have endometrial cancer or other forms of urinary cancer that also are related to that as well. And we wouldn't expect patients to be aware of all the ins and outs of that, but knowing sort of your general family history, and then if it seems like there's cancer in multiple family members over multiple generations, then having that discussion with a healthcare provider who can really determine whether or not you need to undergo further testing or earlier screening would be the thing that I would say would be the most important part of the discussion.
Yeah, I mean, I totally agree. I think that knowing your family history of especially cancer, and if people have died, like why they died, to better be able to tell your healthcare providers, about your history is very important.
Thank you. So we're circling back to an overarching question for you guys. We're going to the end of our questions in our session here. So I want each of you to tell our viewers the one thing you feel is most important for them to know during Colorectal Cancer Awareness Month.
I would say that screening saves lives, and that screening is something that patients do and is not generally painful or uncomfortable. Many patients after their colonoscopy, usually the most common thing that I hear is that the bowel preparation is by far the part of it that they dislike the most. Now that's something that hopefully will be improving in the future, but I would say the biggest thing is that colorectal cancer is a preventable form of cancer. It is also a highly treatable form of cancer, and by identifying it earlier, you can not only affect your life, but you could potentially even save your life because it could be curable or preventable. So the biggest thing is to undergo a test, whether or not that's colonoscopy, talking to your doctor about the appropriate screening test, and undergoing some form of colorectal cancer screening would be the biggest thing that I would like to put forth, that just having the test is the most important thing, independent of what type of test that would be.
Indeed.
Yeah, I agree. I think that screening is very important. And then secondarily, I would say, if you're patient and you're having symptoms that we've talked about, change in bowel habits, bleeding, abdominal pain, that you need to be sure and talk to your doctor, because you may need a colonoscopy to assess and make sure it's not colorectal cancer, even if you're young. Don't ignore symptoms. And if you're unfortunate enough to have been diagnosed with colorectal cancer, come in, see our physicians, get treated. It's often scary when people come in and they have been told the C word and they're very nervous, but this is what we do every day, and we will walk you through it and take really good care of you and get rid of your cancer.
Thank you both. Thank you, Dr. Naylor, Dr. Hardiman, for your time, for your expertise during today's chat. And for our viewers, if you're interested in sharing a recording of today's chat with others, you'll find it on our Facebook page later today, and also on the Michigan Medicine YouTube channel shortly after that. So again, thank you for joining us. Thank you for joining us, and have a wonderful afternoon.